Hello professionals, this is Dr. Saad and as you know we are recording series of lecture for pharmacists who are going to appear for international equivalency exam. In previous video we talked about bone mineral homeostasis. It's some points was missing, so in today's video we'll start from osteoporosis. And first of all we will talk about causes of osteoporosis. There are three prominent causes. Number one is hypercorticosterone secretion, hypoparathyroidism and drop in estrogen level. These are three causes of osteoporosis. As I told you about drop in estrogen level, it mostly happen in most menopausal women. So sometimes this disease affect to men also, but in post-menopausal women, this disease is prominent. So question is that how we would manage it. We will use several drugs which I am going to mention here, which holds the major treatment part in the prescription. So number one is the biphosphonate. Its example is the alendronate. It is given 10 mg per day or 70 mg weekly. But keep in your mind that alendronate shouldn't be taken in lying down or sitting position because it causes esophageal ulcer. Second example is the risendronate. It is given 5 mg per day or 35 mg weekly doses, and ibendronate is recommended in 2.5 mg per day or 150 mg monthly doses. Similarly, zolindronate is given 5 mg daily doses from biphosphonate. We also have examples which is used injectable formulation, and the injection would be sufficient for 3 months. So these are the drugs of biphosphonate which is used for the management of osteoporosis. Second is we use selective estrogen receptor modulator to maintain the level of estrogen. Its example is the raloxifene. And third is the calcium and vitamin D combination, or separately we use calcium and vitamin D. Vitamin D is recommended, you can say it is recommended 800 IU per day. So it is very important for the maintenance of this mineral in the blood. Fourth is the parathyroid hormone recombinant. Its example is the teriparatide. Just keeping in mind that the teriparatide shouldn't be given beyond 2 years. Fifth is the calcitonin, and sixth is the denosumab. It's recommended into the subcutaneous formulation through subcutaneous route, and its dose is 60 mg. Seventh is the strontium ranelate. It's is given 2 gram per day doses in dosage form. Similarly, we also use calcinate, progesterone, androgen, and sodium chlorate for the management of osteoporosis. So our prescription to counter or to tackle the patient with osteoporosis more or less will contain these medicines. Second point is about the hypoparathyroidism manifestation. It has two prominent manifestations. Number one is the hypocalcemia. Number two is the hyperphosphatemia. Just keeping your mind that hyper phosphate you can say phosphate level or PO4 level would always be inversely proportional to the calcium level. Whenever patient is suffering from hypercalcemia, he will also face hypocalcemia. Similarly, if patient is suffering from hypophosphatemia, he would also have hypercalcemia. So these are often remain more or less in an inverse relation. Just it was just for information. Just keep in your mind that manifestation of hypoparathyroidism is hypocalcemia and hyperphosphatemia. Point number three is about the how drugs which is used for management of rheumatoid arthritis. These drugs are termed as anti-rheumatic drugs. So let's talk about its example. Number one is conventional synthetic disease modifying anti-rheumatoid drugs. Its examples are azathioprine, chloroquine, hydroxychloroquine, cyclophosphamide, cyclosporine, leflunomide, methotrexate, and mycophenolate, mofetyl, and sulfasalazine. Keep in your mind that leflunomide belongs to pregnancy X category. It can be asked in exam. Second drug which is used for or which comes under anti-rheumatic drugs are BDMRDs, biological disease modifying anti-rheumatoid drugs. Its example is tocilizumab, rituximab. Third is the TNF alpha blocking agents. Its example is the adalimumab, certolizumab, etanercept, and goslimumab, infliximab, ustekinumab, and secukinumab, tocilizumab. These are comes under the TNF blocking agents. Fourth option is the interleukin 1 inhibitor. Its example is the anakinra, canakinumab, rilonacept, and belimumab. These are the examples of interleukin 1 inhibitor, which is also belongs to anti-rheumatic drugs. Fourth is the glucocorticoid drugs. It holds almost 60 to 70% share for the treatment of rheumatoid arthritis. And the sixth is about the acetaminophen, that is commonly known as aspirin. In acute pain and fever management, it is recommended with a dose of 325 to 500 mg 4 times per day. But for specifically or particularly in case of rheumatoid arthritis, it is used the dose of 4 gram per day. Now it should dose shouldn't be exceed from 4 gram per day. It is mentioned according to the Kaizen, its dose shouldn't be exceed from 4 gram per day. Maximum 4 gram per day can be recommended for rheumatoid arthritis, but in some unauthentic data, it also recommended that you use 6 gram per day. But I will recommend you to stay with the authentic data, that is the 4 gram per day maximum dose. So these are all about the anti-rheumatoid drugs. One drug that is missing, that is the NSAID. NSAID is often used to improve the mobility in rheumatoid arthritis. So these are the drugs which is used for the treatment of rheumatoid arthritis. Next point is about the hypothyroidism and you can say hypoparathyroidism and hyperparathyroidism. How we can manage it is we use calcinate vitamin D analogs for its management. Just keep in mind that dihydrotecassirole, it is also vitamin D analog which is used for the treatment of hypoparathyroidism. But here it is mentioned that for the management of hypoparathyroidism or hyperparathyroidism, in both cases we use calcium and calcinate or vitamin D, because if there is a hypoparathyroidism, then our body would resorb calcium from the bones. We will avoid that. That's why we are using vitamin D and calcitonin analog. On the other hand, for hyperparathyroidism, we also use this to increase the level them in the blood. It will give you a negative feedback to the parathyroid hormone. Just go and review the mechanism which I told you in the start of this bone mineral density. Then you will easily get the basics of this point. But keep in mind that calcinate and vitamin D is used for both hypo and parathyroidism. So this was about the point about this point. Next point is about the, you can say, early mornings. There is a science. There is a problem that is known as early morning symptom of stiffness and rigidity. It is managed by the use of benztropium mesylate. This is a drug which acts as a muscle relaxant. It is actually used in anti-Parkinson disease, but it is also used for the earlier morning stiffness and rigidity management. Next point, that is the point number 8. It is about the gout. As you know that monosodium urate deposition in joint associated with high serum uric acid level. This is serum when serum uric acid level increases, it causes monosodium urate deposition in joints, which causes the condition that is known as gout. I'm not here going to discuss its full treatment plan, but one of its treatment option is the colchicine, that is used for its prophylaxis, and its dose is 0.6 mg once daily at 3 times per day, or we can also say that 500 to 600 mcg per day, 3 times per day, which can be recommended. Colchicine is one of its options. We will discuss about it when we will talk about the excretory system. In that, we will talk about gout. Next point is about the, you can say, we also discuss about the vitamin D analogs. Yes, I think so. We have almost finished all our major points from the bone mineral density. Now I will let you know about the summary of this chapter, and then we will conclude it and start our next chapter, our next topic from endocrinology. As long as vitamin D we use several drugs. Let's talk about in this point with the summary of drugs. Vitamin D metabolites, or you can say analogs. Example of vitamin D metabolites or analogs. We can say cholecalciferol, that is also known as vitamin D3. Ergocalciferol, this is known as vitamin D2. Calcitriol, calcifidol, and dexo. Ergocalciferol, pericalciferol, and calcipotriol. These are the examples of vitamin D analogs and metabolites which is used for the management of thyroid. Various conditions are associated with bone mineral homeostasis. The second is about biphosphonate. Its example is the alendronate, risendronate, ipendronate, pimendronate, and zolendronate. Third is the hormone that is used in bone mineral homeostasis. Its example is the teriparatide, abaloparatide, calcitonin, and RBPTH84. These are the example of hormone. And next is selective estrogen receptor modulator, that is a raloxifene, and next is the rank ligand inhibitor. Rank ligand inhibitor. Its example is the denosumab. Next is the calcium receptor agonist. Its example is the C- cinacalcate. Cinacalcate is a calcium receptor agonist. And lastly, we talk about is the minerals that is used in bone mineral homeostasis. Its example is the calcium, phosphorus, and strontium. So this was all about. Here we are concluding our chapter of bone mineral homeostasis, and next we will talk about diabetes, which is one of the most we can say useful hormone from the endocrinology, and we have a lot of pharmaceutical preparation for the management of its clinical situation. Thank you so much for listening. If you feel that our this video is helpful for you, then please appreciate us by subscribing our channel. Thank you so much.